What to pay attention to when using a George gauge. So first one being, when we try to get this anterior-posterior position right, we really need to keep in mind the range of movement that we have actually then dictates which MRD that we can prescribe. So I'll expand on that. So if the patient needs to have, let's just say, a 10mm range of movement, and you're going to record the position at 0, but it may be that they need to come 10mm forward to achieve the effect that we're after, and your MRD only has a 5mm window, you want to make sure really that you either don't prescribe that device, you need a device that has a 10mm range of movement, or you have to bring them further forward. You have to sort of balance the two. But the key thing is here, we're working from what is the bite registration dictates the device, rather than the device dictating the bite registration. Let's not get the cart before the horse. Next thing we really want to pay attention to is what's going on with the patient's temporomandibular joint. You might want to think in terms of checking radiographs. Do they have clicking, popping? Do you see disc movement? Do they have to capture the disc? If you see this, I would urge you to refer. If the patient's actually presenting with some sort of TMD, I'd either think very strongly about not providing an MRD in this patient, or referring to someone that's comfortable dealing with TMJ dysfunction and MRDs. It's a dangerous area. I would warn you to run away from it if you can. Let's continue. If you're looking from a lateral perspective, you want to look at the facial midline and don't worry about the fact that dental midlines may not line up on protrusion. Don't correct it and force the jaw to line up. The jaw is a position, is what we're after, not so that the teeth are aligned. You want the jaw to move as it wishes, you don't dictate to it. And then you want to observe and record, where does the mandible go during function. If they go forward and they move to the left, great, write it down on the prescription, or the tech may see it as an error, and again they may correct it and move it. You don't want to do that. And then if you're going into this tiger country and with TMJ dysfunction, where does the mandible go when the disc is captured? When they've got back on the disc, where does it go? Write it down and record it. You need this information. And finally, I'd say, is how does the patient look? How do they feel? Write it down. From a vertical perspective, we're looking at the structural elements. Anatomical, therapeutic. Yeah, we want to make sure that we don't over close, and if there have been some attrition on the teeth, we want to make sure that we bring them open a bit. Now, you may also find that if the patient has macroglossia, a very, very large tongue, it may be beneficial to open them up just slightly and allow the tongue to flow over the occlusal surface. But how much vertical opening is too much? This is a very difficult area. Look at the way their face is in profile. If it looks corrected, then and they're not struggling with it, that would be a good starting point. If you see this, you know the answer. Just touched on this before, but what to pay attention to when we're looking at the vertical element, the structural side of things. Well, we need to be aware that we have sufficient clearance for MRD construction. This would normally be about 4mm. So look at all the teeth, not just the incisors, and make sure you haven't got posterior interference as they come forward on protrusion. You need to have room for the upper and lower devices, but to actually go across the occlusion. Look at all the teeth. Do you need then to have some sort of anterior opening to, it may appear that they've actually sort of 10 millimeters open, just hypothetically, between the incisors, so that you have sufficient room between the molars. Do you need to include an anterior disclusion ramp? Again, this is a contentious area. There are two sides to this. One school of thought would actually have it so that you have just incisal contact and posterior disclusion. The other school would say, no, we must have full balanced occlusion, otherwise the molars will erupt. Looking at an anatomical perspective, if there are bruxist and OVD has decreased, I'll consider opening it up to restore it. Bear in mind we want lip competency, and I say as the ideal vertical perhaps is lost, do you want to open them up? And then again, look at, does the patient have a steep mandibular plane? Is there a vertical growth pattern? Has elongated? Look at the tongue size. Do they have macroglossia, and you'd want to actually give a bit more room? If you did have that situation, you wouldn't want to put a device that had the mechanism that was going to invade tongue space. We're trying to increase tongue space to actually give some more room and oropharyngeal. So let's look at from a therapeutic perspective, does adding vertical benefit the patient? Does it help? Does it give more room perhaps? Does it compensate for attrition from bruxism? And then what's too much? When to stop? How much?